Great, everybody. Well, thanks for joining. I'm really happy today to have Dr. James Freeman from our section of cardiovascular medicine joining us today to talk about atrial fibrillation and heart failure. Dr. Freeman is a professor of medicine here at Yale and is the director of our clinical cardiac electrophysiology program. So we're very honored to have him here today. So Jim, thanks so much, and I'm excited to see what you have for us.
Absolutely. Just timing wise, what do I have for timing? Remind me, about 20,
Uh,
30 minutes. Is that
yep,
right?
up to 1 o'clock.
Okay, great. Sounds good. All right, guys. Well, what a pleasure to have an opportunity to speak to this group. My name is Jim Freeman. Reach out to me if you have any questions about this, or if I can ever be of help with patients, of course. Happy to care for anyone who might need our help. Okay. All right, so just a real quick reminder for those that haven't been following the EP literature very well. We're sort of in the halcyon days for EP right now. Have a lot of opportunities to really help a lot of people. And one of the spaces in which things have really grown is in the left atrial ablation space for atrial fibrillation and left atrial flutters. The mainstay of therapy for years is the upper left corner was using a point radiofrequency energy catheter to deliver radiofrequency energy. And the goal in the left atrium was to electrically isolate the pulmonary veins. So in the lower left, you can see those point lesions utilized to electrically isolate the pulmonary veins. The pulmonary veins have these muscular sleeves that put out these electrical triggers that then kick off atrial fibrillation. And so it's been demonstrated. Actually, the seminal observation was made by Michel Hasseguer in Bordeaux, France, that these triggers were the causing trigger for atrial fibrillation in a vast majority of patients with AFib. Cryoballoon is the other energy that has historically been utilized until basically the last year. So that's nitrous oxide in a balloon that then freezes around the pulmonary veins and again electrically isolates the pulmonary veins so that those electrical triggers can't get out of the pulmonary veins. Most recently, I don't have a picture of it on this slide, we use pulse field energy. Pulse field energy is actually direct high voltage electrical current applied to the tissues. And the interesting thing about that is that it's largely cardioselective. It also actually does cause some hemolysis if exposed to the blood pools. So we try and really have good contact to make sure it's largely applied to the myocardium. But it doesn't impact to a large extent, it has minimal impacts on vascular tissues and the esophagus, both of which were historically problem areas for us. So there's some data that if you apply directly onto a coronary, you can end up with some intimal hyperplasia, but not the really thrombotic findings that we used to go to RF directly on a coronary. So those are the technologies being utilized right now. In terms of safety, the acute complication rate of AF ablation is about 1 to 2% in contemporary cohorts. That's down from about 2.5% a few years ago. So probably about 5 to 10 years ago, we published some work, and then more recent work showing 1 to 2% in a study we just published of probably the largest world registry of AF ablation. And that is consistent with what's been found in a lot of the recent randomized trials, most of which are on the order of 200 to 400 patients. The vast majority of complications are groin bleeding and vascular complications. In terms of major complication, perforations reported in about 0.5 to 0.7% of patients. There's a bit of an operator, kind of a learning curve associated with that complication in particular. Major bleeding, about 1 in 1,000, stroke, about 1 in 1,000, death, and about 1 in 1,000 to 1 in 10,000. So overall, this has become a pretty safe procedure, or a very safe procedure by cardiovascular procedure standards, and now taking on the order of 1.5 to 2 hours. And really has gotten more effective over time. In terms of the effectiveness literature, rates of freedom from atrial fibrillation with AF ablation plus minus antiarrhythmic drugs, and in some cases multiple procedures, is about 60 to 80%, with studies going out 1 to 2 years for paroxysmal atrial fibrillation, about 50 to 60% for persistent AF, again, with studies going out 1 to 2 years. We know that there's some ongoing recidivism as we get further out. So by the time you get to 5 years, there's definitely, some rate of recurrence that continues. So it's not as though you get to the 2-year mark and you're home free. We can see some ongoing rate of recurrence of AFib even after that. But most of the studies go, again, 1 to 2 years. Any questions about AF ablation just as we start? Okay. The other thing is, so this is actually, these are this is a slide of original rotor mapping. And actually this, there was a lot of promise here, which is the idea that we should be able to target. We know that the pulmonary veins aren't the whole story in atrial fibrillation, of course. And so the question is, can we figure out in individuals where there is activity that's either initiating or perpetuating their atrial fibrillation, particularly in those with a more persistent form of AF, and map that and then do some type of ablation approach to get after that. So this is from Topera, which was the original salvo on this, by Sanjeev Narayan, who's out at Stanford, is a good friend. And unfortunately, this kind of didn't work out, whether it was because of the mapping strategy and it was just too rudimentary at the time, and or the ablative strategy, which was sort of left up to the, to the judgment of the provider. It just didn't turn out to be a very effective strategy. More recently, there's something called electrographic flow mapping, which is trying to do the same. Actually, a good friend of mine from medical school has been very involved with that. And then a former Stanford colleague who is now in industry kind of working on that. And that was just sold to Boston Scientific. So it's probably got some legs because they've really made a lot of savvy acquisitions in the last 5 to 10 years. So we'll see. I think there's reason to believe that hopefully in the next 5 to 10 years, we'll have some technologies that allow us to map triggers and perpetuators outside of the pulmonary veins. All right, so let's talk a little bit about atrial fibrillation and heart failure. Over 30% of heart failure patients have atrial fibrillation, and it's pretty common for patients with atrial fibrillation to develop heart failure, as you know. The two conditions are synergistic, so AF can cause or exacerbate heart failure, and heart failure can cause or exacerbate atrial fibrillation. So there's a pathologic synergy there that can be really important to try and unwind, and so that's what we'll be talking about today. So this is sort of historic data on some level, but I think of interest to this group. So AF ablation and patients with systolic dysfunction, and I'll tell you that we're going to be talking today about systolic heart failure. So people with low ejection fraction, the data is much more limited. There's really not trial data for patients with diastolic heart failure with preserved ejection fraction. That there's actually a randomized trial that is ongoing right now that hopefully will get at that population. And obviously we have a lot of anecdotal evidence that it's, until very recently, was basically one of the only things we could offer patients with heart failure with preserved ejection fraction. But the trial data is much more limited. And so we'll talk mostly about systolic heart failure. So a bunch of very small studies back in the day that when meta-analyzed showed a trend towards an improvement in EF of about 10%. And I think that actually is a number that bears out over time. And so we'll talk about this as we talk about some of the more contemporary data. But I think it just shows the value of some of these small early studies and doing meta-analysis of that and trying to get a signal from that, which can then inform future trials. And I'll also tell you that, when I started EP, which was 14 years ago when I started EP fellowship, there was a lot of nihilism about the ability for us to really achieve rhythm control in the context of patients with systolic heart failure, and a lot of nihilism that even if we did that, was it really going to make a difference in these patients who already had a reduced ejection fraction? And so it's really been very satisfying to see the evolution of the space. So this was a study, the PABA-CHF study, which is a study of pulmonary vein isolation versus AV nodal ablation and bivalve pacemaker implant in patients with atrial fibrillation and congestive heart failure. The mean age was 60. About half the patients were persistent and half were paroxysmal, and the mean EF was 28%. So 177 patients screened, 81 randomized, about 40 in each arm. And a composite endpoint here was left ventricular ejection fraction, a 6-minute walk. And those are really the two, I would say, the two big outcomes here. All right, so again, what you see here is that in patients who underwent pulmonary vein isolation compared to those with AV node and BiV, there was a marked improvement in left ventricular ejection fraction. Again, that number about 8 to 10%, consistent with some of the prior trial literature. 6-minute walk, an improvement in 6-minute walk, and then when, actually also the Minnesota Living with Heart Failure questionnaire, again, relative improvement. Okay. All right, the CAMERA-MRI study was then the next study that came out in this space. This was 68 patients with persistent atrial fibrillation and idiopathic cardiomyopathy randomized to AFib catheter ablation or rate control. Inclusion criteria here included persistent AFib. Importantly, this was a particular brand of patients, so they had to have idiopathic cardiomyopathy and they had to have an EF less than 45%. So on MRI, they had to have low ejection fraction without substantial evidence of scarring, and they couldn't have prior coronary disease and whatnot. So it had to be people for whom basically we thought that it was likely that this was tachycardia-induced cardiomyopathy. And so I think a particular subset of patients, but informative nonetheless. So they screened, and you know, this is important. They screened 300 people to get 77 enrolled and then 68 randomized. You know, so I think that speaks to these sort of restrictive criterion around what type of cardiomyopathies people had. So you can see a lot of these exclusions are people who they've discovered had ischemic cardiomyopathy. The MRI showed substantial scarring. So again, getting at these folks who we think they're likely tachy-induced. Ended up with 34 people randomized in both arms, and then this was the findings. So what you can see is that a primary endpoint was a change in left ventricular ejection fraction at baseline in 6 months by treatment arm. So what you can see is that there was a marked improvement in left ventricular ejection fraction. So again, this is in this particular subset of patients who we thought it was tachy-induced cardiomyopathy. Turns out our best available therapy for getting people in normal sinus rhythm is a pulmonary vein isolation. The literature would suggest, we didn't get into this, but the literature suggests it's about twice as effective on average as antiarrhythmic drugs. And that's true in a general AF population, and it's also true in the heart failure population. I think I'll show some data later on that. But certainly our most effective therapy. And so by undergoing pulmonary vein isolation, when we can achieve durable rhythm control, we can see marked improvements in left ventricular ejection fraction. Actually, one data for posterior wall isolation, except in people with highly fractionated high frequency signals. There's some data from the trial literature to suggest that that may be advantageous. And in fact, with these lines, sometimes you can create substrate for posterior flutters and whatnot. That paradigm has changed a bit in the context of pulse field ablation, where it's very easy to electrically isolate the posterior wall. And so I think there's been some reassessment of that because we can achieve durable isolation of the posterior wall in a way that we really couldn't with point catheters in the past. Just again, EF normalized in 58% of patients with ablation versus 9% with medical therapy. And those undergoing ablation, absence of LG on MRI predicted greater improvements in absolute left ventricular ejection fraction and normalization at 6 months. Okay. Good. All right, the next study was the AATAC trial. So this was a randomized trial of 203 patients assigned randomized to AF ablation versus amiodarone. The inclusion criterion here were persistent AF. Importantly, these patients had a dual chamber ICD or CRTD, New York Heart Association class 2 to 3, and EF less than or equal to 40%. So the device here is really important because, again, it gets at this question of can we achieve rhythm control at the rates that we can with a general AF population? And so having a 24/7 monitor with intracardiac signals was really helpful in terms of definitively establishing that. So again, here we go, 203 patients randomized, about 100 in each. And this was the take home from that trial. And what it showed is this is freedom from atrial fibrillation or atrial tachycardias going out to 36 months. And so what you can see is essentially that AF ablation is about twice as effective, and the rates from freedom from atrial fibrillation, again, with using intracardiac signals from their implantable cardiac defibrillators, showed that that ablation was about twice as effective as amiodarone at maintaining normal sinus rhythm. So really, I think definitively answered a super important question in the field is, can we achieve rhythm control in these people? And then having achieved rhythm control, what were the outcomes? So the outcomes were that there was a marked reduction in all-cause hospitalization. This was actually the first study to show a reduction that was statistically significant in mortality. It was not a primary endpoint, it was a secondary endpoint, but really important finding. And I think the first time people said, wow, we might be able to bend the curve on mortality in systolic heart failure. And that was the first time actually that we had seen a mortality improvement associated with pulmonary vein isolation. Okay, so the Castle AF study was then really, I think, the pivotal trial in this space. It was a randomized trial of pulmonary vein isolation versus conventional therapy. Conventional therapy could include rate control or rhythm control. So it wasn't super prescriptive about how people were treated. And so I suppose, depending on how you could look at it, you could look at that as a weakness of the trial. But it, I think, is actually probably appropriate in that it was randomization of a procedure versus how would a physician treat this person in the real world, based on on their brand of atrial fibrillation and heart failure. And in some cases, that's going to be rate control. In some cases, that's going to be rhythm control. Patients had to have symptomatic paroxysmal or persistent AFib, failure or intolerance of one or more antiarrhythmic drugs, left ventricular ejection fraction less than 35%, New York Heart Association class 2 or greater. And again, patients had to have a defibrillator. And so again, I just can't highlight enough how important it was to have this kind of monitoring and be able to know definitively what was happening with regards to AFib. So we ended up with about 180 patients in either arm. And then we'll talk a little bit about this, some crossover, but overall pretty good. Primary endpoint was all-cause mortality, and then worsened heart failure admission. So I think you can see the evolution of the studies in this space, that you get a mortality signal, and now it becomes a primary endpoint for this definitive larger study. These were the conventional therapy arms, so what was utilized. So in green is sort of the rate control agents, beta blockers, DIDs, calcium channel blockers, and AV nodal ablation in 5 patients. Rhythm control was used in a lower percentage, but still a substantial number of patients treated as well. Okay. All right. So this is a really nice slide just showing the percent of patients having atrial fibrillation over time. And so what you can see is in the conventional therapy arm, basically immediately at the 3-month follow-up and then extending out to 60 months, marked difference in terms of freedom from atrial fibrillation with ablation versus conventional therapy. In the ablation group, there were some complications, and I would say that this is now slightly historic in that rates of safety events have really been driven down, particularly in the last 5 years with really all our ablative technologies, and certainly with pulse field ablation. But they had a little higher rate of pericardial effusion in this group than we would normally expect. Certainly a higher rate of stroke or TIA. And I think this is something worth following, that the risk of stroke or TIA in patients with systolic heart failure is higher, and we need to be really cognizant of that. I've been doing this 14 years, and knock on wood, I've never had a stroke during an AF ablation or in the immediate aftermath. But it is something that we see in the literature is occurring. Again, these rates are a bit high compared to what we would expect in the current era, even in this population. But there was just a study I was on the DSMB for using pulse field ablation, and they had a slightly higher rate of stroke, which has been under 1% in virtually every pulse field ablation trial. They had a slightly higher rate, closer to 2%. And that may be, again, in this, very high risk population in people with heart failure and very high CHA2DS2-VASc score, you have to be more cautious in that group and really be very careful about pre-procedural imaging for thrombus in the left atrial appendage, and/or ensuring that patients are on uninterrupted anticoagulation and using a higher ACT goal during the procedure. So left ventricular ejection fraction improved by 8% in the ablation group at 5 years. So that, again, is, I think, very consistent. We've talked about that number, 8 to 10% consistent improvement in left ventricular ejection fraction. And that's a durable finding over time, which was important in this study. We didn't have 5-year data in some of these prior studies. All-cause mortality and worsening heart failure, which was a composite endpoint, a very substantial reduction, about 40% reduction in the point estimate, a 50% reduction in all-cause mortality, about a 50% reduction in heart failure, 40-50%, about a 50% reduction in cardiovascular mortality, and about a 30% reduction in cardiovascular hospitalization. So I would say this study really changed the game. And now our guidelines have reflected the findings of this trial, which was really stood on the shoulder of giants in terms of prior studies that really built to this finding. And now our guidelines recommend the use of catheter ablation for rhythm control in patients with systolic heart failure. And, I would say a win for us is in the wake of the publishing of this trial. Dan Jacoby, when he was running our heart failure group here, ended up incorporating AF ablation and AF rhythm control into his note template for systolic heart failure, just as we would with any fundamental component of GDMT. So sort of like GDMT, consideration for a defibrillator, atrial arrhythmia management. And I really, there's very strong evidence at this point, and so I would strongly suggest that everyone be thinking about it just as they think about Entresto and Farxiga. For every patient with systolic heart failure, we should be thinking about, do they have atrial arrhythmias, and is there an opportunity to manage them? Obviously, caveats to this, and I may have a slide here. This is just subgroup analysis showing that overall, these findings were very consistent in all subgroups. The one group that we need is a bit of a caveat is at the very bottom here, is those with ejection fraction less than 25%. Okay, so I think it's important to recognize that there may be a muted benefit in the context of people whose EFs are too far gone. And then similarly, just as in any patient with atrial fibrillation, if they've been in permanent AF for more than 2 to 3 years, it can be a heavy lift. We certainly have had a few people for whom you're still able to rhythm control them after that period, but I'll generally start with a trial of sinus rhythm with a cardioversion and see how that goes to give me some sense of whether I could even get the patient out with a cardioversion, and then kind of go from there. And you can look at how dilated the left atrium is, and other markers. But I would say, permanent AFib more than 3 years, or very low ejection fractions, you need to be thoughtful about that. Now, the caveat to that, and I don't have slides on this trial, I need to add that study to this, is the Castle HTX study, which was actually then in people who are being considered for transplant with very substantially reduced left ventricular ejection fractions. That actually also showed a substantial benefit with hard outcomes in those patients treated with pulmonary vein isolation. So it sort of flew in the face of that finding in the subgroup analysis from the Castle AF study. And so it sort of said, well, we really, even if someone's very, very sick, we could be considering ablation. Again, within reason. I think if someone's got class 4 heart failure, you're going to have to be thoughtful about that. But I think the take home is that across the vast majority of patients with systolic heart failure, this is something we ought to be considering. So in conclusion, AF and heart failure commonly run together. AF rhythm control with ablation should be considered for those with systolic heart failure as a primary treatment modality, particularly those with idiopathic or non-ischemic cardiomyopathies. So idiopathic non-ischemic cardiomyopathy, but strong evidence as well in ischemic cardiomyopathy. Studies, while relatively small, consistently show improvements in outcomes, including left ventricular ejection fraction, heart failure admission, functional improvements, and then improved survival in 2 recent trials. And that's it.
Thanks, Jim. That was fantastic. We got a question in the chat for you.
Yeah.
It says, how often do you see stiff left atrial syndrome after ablation?
Yeah, I can't say that. So we are pretty parsimonious with our ablative strategies here at Yale. So meaning, there are people going out there and just taking out particularly in the era of pulse field ablation, it's pretty straightforward to take out huge swaths of the atrium. I can't say I've clinically ever had where I knew for certain that I certainly, had stiff left atrial syndrome. We will see some patients with progression of their heart failure, but I've never had someone who developed substantial heart failure that I thought was due to stiff left atrial syndrome, who did not have any evidence of heart failure in the past. It can be a little bit of a difficult diagnosis to make, and so it's possible that we have had people who developed diastolic, atrial diastolic dysfunction in a way they didn't in the past. But you have to remember that, maze procedures were done on many, many, many people for many years without an enormous amount of consequence and whatnot. So, and we have patients with congenital heart disease for whom their atrium are really passive conduits. So, well, we know that an atrial kick, we do our best to preserve the atrial kick, and AV synchrony is really important. I think we have a little more latitude than it might seem intuitive to do ablation and have it benefit people overall.
We have any other questions from the group?
Hi,
I just had
another question.
oh, yep, go ahead.
Hi, thank you so much, Dr. Freeman. This is great. I was wondering, what's your threshold for kind of going to the AV node ablation? Is how many ablations? Like a certain number of ablations, or I guess what's your kind of approach to that?
Yeah, so I would say with or without systolic heart failure, if we can't get it's really patient dependent. You kind of have to use your clinical judgment a little bit, but if we really can't get the AFib under reasonable control with 1 or 2 ablations, and somebody's really doing poorly, then I think that's a reasonable alternative. And I think there are certain circumstances where if you have Tachy-Brady syndrome, we're very careful to say we can't guarantee that we're going to be able to perfectly rhythm control people. Again, the data would suggest about 60 to 80%, with most studies converging on about 60 to 70% freedom from atrial fibrillation 1 to 2 years. So if you have someone with bad Tachy-Brady syndrome, for example, where they're really fast and then really slow, it's hard to guarantee that you're going to rhythm control them well enough that you're not going to run into the bradycardic element and whatnot. So I would say, those are situations we think about it. People with extremely fast AFib, that no matter what we do, we cannot get the rates under control if they have AFib. And then people that have had, 2 or 3 ablations, and we just can't get it under control.
Do you have like a lower threshold if they've had if they have severe LV dysfunction, less than 25%, that population, do you tend to kind of move to it faster?
Yeah, so I would say, again, based on the Castle HTX data, I was wary of those people after Castle, and then based on the Castle HTX data, if someone's ambulatory, and they don't have class 4 heart failure, even if their EF's pretty darn low, particularly in the pulse field here. You have to understand one of our concerns in the past is that it was, you know, a 4-hour procedure under general anesthesia. And now it's like an hour and a half. You know, so we can really get this done, minimal impacts of anesthesia, minimal fluid during the procedure. So we're not using irrigated catheters anymore. You know, the catheters are minimally irrigated to prevent thrombus, but not in the same way as a radiofrequency catheter where they were getting 2 or 3, sometimes 1.5 or 2 liters of fluid and or even more with a long procedure. So I wouldn't, just because someone's EF's less than 25%, I'm not necessarily excluding them. I think once we get down into like under 20%, you need to be really thoughtful.
Thank you.
All right. Well, thanks everybody for joining today. Dr. Freeman, again, thank you so much for your time and sharing your knowledge with us. And
thank you so much. And, certainly reach out if I can ever be of help with patients or if you have questions about the field broadly. Thank you.
all right. Have a great summer, everybody.